The broadcast is now starting. All attendees are in listen-only mode.
All right, so we'll get started. I wanted to thank everybody for tuning in on tonight's webinar. Again, we are holding a free EBFA webinar first Thursday of every month. If you happen to miss any of the EBFA webinars, they are all archived and kept on the EBFA website, which is ebfafitness.com. My name is Dr. Emily Splichal. I'm the founder of EBFA. I'm also a podiatrist in New York City, human movement specialist, and corrective exercise specialist. So if this is your first time tuning in the webinar, how it's going to work is we will do roughly a 20-minute lecture. Tonight's is very exciting because it has to do with research that we've done on behalf of EBFA. And then the last 10 minutes we can ask some questions. There's an area on your panel where you can type in some questions, and I will go over those at the end to hopefully answer anything that you may have. So we're going to get started. Beyond stretching. So we're going to start teasing this idea of trigger points and limited ankle mobility. And maybe we can start getting a little bit more effective increases in ankle joint dorsiflexion in our clients, in our athletes, that looks beyond just static and dynamic stretching. So as we get started, so ankle mobility. Why do we need ankle mobility? How much ankle mobility do we need? And what are the compensations for inadequate ankle joint dorsiflexion? So pretty much any activity of daily living requires ankle joint dorsiflexion. From going upstairs, going downstairs, squatting, jumping, walking requires ankle joint dorsiflexion. If we do not have that adequate ankle joint dorsiflexion, our body is going to compensate. So our body is going to compensate both distally into the foot and proximally into the knee, the hip, and the lower back. So your role as a fitness professional or a strength coach is to assess your clients and your athletes for ankle joint dorsiflexion, and if they have inadequate dorsiflexion, can you identify the compensations that they're presenting and decrease their risk of injury by adequately and effectively increasing their ankle joint dorsiflexion? So how much dorsiflexion do we need? It's pretty amazing how much dorsiflexion people think that we need and how much we actually have. In my workshops, I go into and demonstrate, and everybody assesses each other for ankle joint dorsiflexion. And you would be surprised how many people do not have enough dorsiflexion. According to root theory of biomechanics, we need at least 10 degrees of ankle joint dorsiflexion. If you're unfamiliar with root theory of biomechanics, this is based around subtalar joint neutral and then testing the ankle for ankle joint dorsiflexion. When you put the foot into subtalar joint neutral, most people have 0 to 5 degrees of ankle joint dorsiflexion. Many people, as I'm doing my workshop and assessing, and in patients I see every day, most people have a negative ankle joint dorsiflexion. That means to even stand in a quiet stance with that ankle in a 90-degree angle, their body is compensating to stand vertical. It's quite impressive when you start looking at ankle joint dorsiflexion and the way that body's going to compensate. So as a fitness professional, athletic trainer, strength coach, you need to know what are the top 3 compensations for inadequate ankle joint dorsiflexion. What is that body going to do if it cannot get over the ankle? That body is going to start taking subtalar joint pronation. So that subtalar joint, that mid-tarsal joint, we're going to start over-pronating. We're going to start going into a genu recurvatum. So I'm going to take that range of motion out of my knees. And then that ankle joint dorsiflexion is going to shift all the way up to the pelvis. I'm going to shift my pelvis forward into an anterior pelvic tilt. So again, first compensation that we need to be able to identify is excessive subtalar joint pronation. So we can see here in this runner, if I cannot get over my ankle joint in a closed stance or mid-stance position, my midfoot is going to pronate. The more I pronate, I'm going to start stressing my posterior tibial tendon, eventually leading to what is called posterior tibial tendon dysfunction. So I'm wearing out my posterior tibial tendon, which then leads to even further foot deformity. We start getting first ray or medial column hypermobility. So this is the entire support system from your big toe all the way to your heel. We're going to start breaking down that midfoot and that medial ray, and we start getting our bunions. Because my foot is very much correlated to my knee, any excessive motion I have in my subtalar joint is going to be translated up to my knee, which will then increase my risk for patellofemoral knee pain and ACL injury. So if you're with any athletes or runners and they have decreased ankle joint range of motion and you're not assessing it or adequately addressing it, these are the athletes and the runners who are going to get hurt in their knee. So again, it's extremely important to be able to identify that. Second compensation that we need to be able to identify is genu recurvatum, or hyperextension of the knee. Hyperextension of the knee, we clearly can see how this would increase our risk for osteoarthritis. So if I cannot get over my ankle joint, I'm going to take that range of motion out of my knee joint. The knee flexion and ankle joint dorsiflexion is one of the most important mechanisms that our body has for absorbing ground reaction forces. So when we walk and we jump and run, we need that ankle joint dorsiflexion, knee flexion to absorb and dissipate ground reaction forces. So hyperextension of the knees, that's going to decrease your body's shock absorption. Final compensation we need to be able to identify is an anterior pelvic tilt. Now what's interesting about the anterior pelvic tilt and decreased ankle joint dorsiflexion is that this is one that's a little chicken before the egg thing. Is it my anterior pelvic tilt that is causing my ankle tightness or my decreased ankle joint dorsiflexion, or is my ankle joint tightness leading to a genu recurvatum, which is then leading to my anterior pelvic tilt? So if it is the case that my tight calves are causing my knees to compensate into a genu recurvatum, what is going to happen is my femurs are going to be shifted cephalad or towards my head, which will then push my pelvis forward into an anterior pelvic tilt. So that is the ankle dorsiflexion or calf tightness driving the anterior pelvic tilt. Conversely, if I have a anterior pelvic tilt due to overactive hip flexors, or you have a sedentary position, you're sitting all day, that will then cause a tightness of my hamstrings, which will go all the way down the posterior chain and tighten up my calves. So it's very important to know which way we're addressing it. Is the calf tightness leading the anterior pelvic tilt, or is the anterior pelvic tilt a compensation that is leading to the calf tightness? Very important. Have that anterior pelvic tilt that leads to hyperactive hip flexors and a gluteal and mesial low back pain from that altered reciprocal inhibition. So very important to kind of correlate and assess that. So now it's time for our ankle joint assessment. How are we going to effectively assess our clients or our athletes' ankle joint range of motion? And once we assess that ankle joint range of motion, how do we know that it's due to tight calves? Is it my gastroc? Is it my soleus? Do I possibly have a bony block, or is it structural? So there's a lot of different contributing factors to decrease ankle joint range of motion. You need to be able to identify which one is it in your client or your athlete. So it makes it a little bit more difficult. So we're doing our assessment. Okay, so we're doing either the open chain, which is the bottom left picture. This is me assessing somebody's ankle joint dorsiflexion. We're following root theory of biomechanics. So we're putting that subtalar joint into neutral, and then we're dorsiflexing that ankle. Again, we're looking for 10 degrees of ankle joint dorsiflexion. When you hold it in that position, you're going to have your client or your athlete bend the knee of the leg that you're on. If you see an increase in ankle joint dorsiflexion, you will know that that is the gastrocnemius that is limiting their ankle joint range of motion. If you put the subtalar joint into neutral, dorsiflex the foot, and then they bend the knee, and you get no increase in ankle joint dorsiflexion, you know that it is either the soleus or the whole complex that is contributing. The image on the right, you're having your client or your athlete dorsiflex the ankle and flex the knee until the knee touches the wall. You want the heel to not lift as they're flexing. So again, you're trying to get that knee to touch the wall, getting maximum ankle joint dorsiflexion, and you want that calcaneus to stay on the floor. That would be a functional closed chain ankle joint dorsiflexion. Oops. So again, when we're assessing bony block soft tissue contraction, we must consider our client's occupation, postural imbalances, structural deformity, occupation. If I stand all day, that means my soleus is contracting eccentrically to keep me stable. So my soleus would probably be contributing to my decrease in ankle joint dorsiflexion. Postural imbalances, you have to start teasing that idea. Is that anterior pelvic tilt causing my tight calves and restricting my ankle joint dorsiflexion? Or is my ankle joint restriction and tight calves leading to the anterior pelvic tilt, and that is the compensation? The image on the left, this is showing a passive way of bringing a bony block back into position. So the talus, which is the bone that forms within that ankle joint, you have the tibia, the fibula, and then the talus sits right in between there. And your leg will glide over that talus, and that is what gives you your ankle joint dorsiflexion. If that talus is shifted forward, so you have an anterior shift of your talus, which is very common in dancers, then that will restrict your ankle joint range of motion as a bony block. So this taping here on the left is an example of passively getting that talus back into that ankle joint to increase your ankle joint range of motion. In my workshops, I go into a passive towel stretch. You can teach your clients or your athletes to press the talus back into that ankle joint, which will then increase their ankle joint range of motion. The picture on the right, that is a high-arched cavus foot type. Again, I go into this more detail in my workshops, but I explain that structurally a high-arched foot type can have an innate tightness to their gastroc and their soleus or their Achilles tendon. This means that you can stretch and stretch and stretch these clients or athletes' calves, and you will not get an increase in ankle joint dorsiflexion. You will actually be micro-tearing or micro-damaging the tendon, leading to an acute tendinitis in that foot type. So that foot type trigger point release, extremely important. So we're going to start teasing this idea. We're moving beyond stretching. So you typically have a client, you have an athlete, you see, okay, you have decreased ankle joint range of motion. You're beginning to compensate. I see you overpronating or you're hyperextending your knees. Let's stretch, right? Daily stretching. What's interesting is that studies have shown that chronic stretching, you can stretch every single day your calves, and you will not get an increase in ankle joint dorsiflexion that stays. So a chronic increase in ankle joint dorsiflexion is not seen with daily stretching. It is seen in hamstrings and quads, right? You start getting these chronic increases in ankle joint range of motion. That means that perhaps there is a more effective technique to increasing ankle joint range of motion that does not involve stretching. And this is where we look at our trigger points. So trigger point is just like a knot in that rope. So it's restricting our muscle fibers from moving on each other and therefore limiting our mobility and flexibility in a muscle. Gerwin 2004 explains a myofascial trigger point as a zone of tenderness or pain in a hardened muscle band that will refer pain. So that's an active trigger point. We can have inactive or kind of quiescent trigger points that are not actively tender, but will still restrict our mobility just like an active trigger point. So another study by Wu showed that chronic myofascial tightness of the calves restricted ankle joint dorsiflexion. So there's a lot of research starting to put out there trigger points and hypomobility. How can we address these trigger points and hopefully increase mobility of those calves? Okay, so again, we're starting to tease this idea. Why in the lower extremity? Why do we have all these trigger points in the lower extremity? And the answer to that is eccentric contractions. Okay, so eccentric contractions, more so than concentric and isometric, form trigger points. If you start looking at the biomechanics and the dynamic foot and ankle function, we require eccentric contractions with every step we take. So we're decelerating with that foot. We're going mid-foot pronation. That is all eccentric contractions. All those eccentric contractions are going to start forming a lot of trigger points in the muscles that support the foot and the ankle. We had the example earlier of the client or athlete that stands all day, right? When we stand, quiet stand, vertical, our soleus is contracting eccentrically to prevent us from falling forward. Soleus is one of the most common muscles to have a high incidence of trigger points. So, great study. This is kind of one of the first studies to tease this idea of trigger point release and increasing ankle joint dorsiflexion. Grieve, it was done in 2011, had 20 subjects with decreased ankle joint range of motion. So they had less than 10 degrees of ankle joint range of motion. And they were specifically seen in the soleus. Remember, that's one of the muscles that has the highest incidence of trigger points. So they then did a manual trigger point release, and they had a mean increase in ankle joint dorsiflexion of 3.3 degrees, which isn't too bad after one treatment. So this is immediately after manual release of the trigger points. One subject had 12 degrees, which is pretty impressive, and 3 subjects had a 5-degree increase in ankle joint range of motion. So now we're moving on to the studies that we did with trigger point performance therapy and EBFA. So we did 2 studies. The first one is a little bit more on ankle joint dorsiflexion, and then the second study is a little bit more exciting as it has to do with more dynamic movements and more sports performance. First study that we did, we had 10 subjects. We went through, did kind of a foot typing where they over-supinated, over-pronated, and then looked at their baseline ankle joint dorsiflexion at heel strike, mid-stance pronation, and mid-stance ankle joint dorsiflexion. They then did 5 minutes of trigger point release, which is through the myofascial compression technique, which was created by Trigger Point Performance Therapy utilizing their footballer. And they targeted the soleus, the gastroc, perineals, and post-tib. So again, we're doing the 5 minutes of the MCT, which follows Trigger Point Performance's pre-gen program. And then we did the assessment of them walking, again looking at heel strike dorsiflexion, mid-stance dorsiflexion, mid-stance pronation. What we found is that after just 5 minutes of MCT before walking, we had this altered foot and ankle mobility in all of the subjects. 2 of them that we're going to kind of pull out and look a little bit closer is a first subject, number 7, had a more supinated foot type. And we saw an increase in ankle joint dorsiflexion both at heel strike, not as much as what we saw at mid-stance. We had this mid-stance increase in ankle joint dorsiflexion. Remember that increase in ankle joint dorsiflexion is how your foot begins to absorb shock and ground reaction forces. Second subject, number 9, this is a little bit more over-pronated, had again this increase in ankle joint dorsiflexion at heel strike and a decrease in mid-stance pronation. Now what's interesting is with that pronated foot type, that mid-stance pronation decrease could be because there was less of a compensation needed because they were able to get over their foot. So again, very interesting. This is after just 5 minutes of MCT before walking. Second study that we did was, again, a little bit more dynamic. So we use this OptoGate technology, which uses LED sensors. It's very cool technology. It was done at Peak Performance in New York City. Again, we did a little gait analysis. They ran in place. They squatted, squat jumps, ski jumps, lunges, and looked at their dynamic foot function after, again, 5 minutes of MCT. So again, we're going to pull out 2 subjects. Both of them had flat foot. Both of them had decreased ankle joint dorsiflexion. And what we saw in one of the subjects who was doing the squat jump, So every time he came down, he required that ankle joint dorsiflexion on landing and before pressing up. We had this 86% increase in height after just 5 minutes of MCT, which is pretty interesting. Second subject, again, flat foot type, we had 65% more consistent on his ice skater jump test. Other tests that we did, which is really interesting, this one is for anyone who deals with runners and athletes that we need agility. After 5 minutes of MCT, we had a 71% decrease in this subject's contact time. This means that he's getting more power out of his foot and more reaction time after just 5 minutes of MCT or trigger point release. So anyone who deals with runners, it's that contact time that's when our runners and our athletes get injured. So if we can have a technique that not just increases ankle joint dorsiflexion, but minimizes our contact time, we're then going to decrease our clients and our runners and our athletes' risk of injury. Pretty cool. So almost done. We're starting to look at the applications. So if we're doing MCT before an athletic activity or we're running, we're going to improve our shock absorption because we're increasing ankle joint dorsiflexion. We're getting increased mid-stance pronation, which again is going to decrease our risk of overuse injury with better shock absorption. If we have any clients or athletes who are suffering from chronic plantar fasciitis or Achilles tendonitis, both of these conditions are classically associated with decreased ankle joint range of motion. So we can start increasing that ankle joint range of motion with the application of MCT. Simons et al. Showed that there's these trigger points that can radiate into the bottom of the foot and often get confused for plantar fasciitis. So again, another great application. Last application is if we do this MCT before activity and we increase that ankle joint dorsiflexion, we're going to decrease that mid-foot pronation, which is a compensation. If you can't get over your ankle, you're going to pronate through the midfoot. That midfoot pronation, again, is going to translate up into the knee, causing valgus strain, and increase that runner, that athlete's, or that client's risk of knee pain, knee injury, and most importantly, an ACL injury. So that's the trigger points beyond stretching. If you have any questions, you can start typing them in. Our April webinar, again, very exciting one, which is on foot and ankle fusions and how does this impact human movement. So if we start really looking at the foot and the ankle, and we know that it plays a critical role in ground reaction forces, balance, and human movement through the knee, the hip, and the back, what happens if you fuse the foot? Where does all that motion go, and where does all that ground reaction force go? So we're going to start teasing into that idea. If you're new to EBFA or you want to check out some of our workshops, please visit our website, ebfafitness.com. We have a great lineup of workshops coming up. We have Atlanta, New York City, Chicago, and Boston. So I encourage you guys to check out the website, follow us on Facebook, and we have a great blog that has bi-monthly posts on functional foot and ankle, barefoot training, and corrective exercise. So again, thank you guys all so much for tuning in. If you have any questions, please type them in, or if you ever want to reach out, then please do not hesitate to contact us at education@ebfafitness.com. Okay, so we have our questions. Let's see, trying to read them. Okay. Ankle mobility dysfunction. What tips do you have for self-diagnosis and treatment of ankle mobility and dysfunction? Again, what tips do you have for self-diagnosis of ankle mobility dysfunction? I would try and have somebody either record you while you squat, you do that functional test, and you can watch yourself from both behind. So have somebody record you as you squat from behind so you can see your heel bone or your calcaneus. What is it doing, right? Take pictures of you in both the frontal plane, the sagittal plane, and from posterior, look at your knees, look at your pelvic position. That allows you to do a self-diagnosis, and then you doing squats, step-ups, step-downs will show how you are functioning in a more dynamic moment. and then you can increase that ankle mobility. You can go to a podiatrist and they could assess for you, or try doing, if you suspect you have an anterior shift of your talus, try doing some of those passive techniques, taping the talus back, putting a towel which can press the talus into a posterior glide, and see if any of those increase your ankle joint range of motion. How long does the benefit last for runners? This is a common question that we got. Sugar Point Performance and I presented this research at IDEA, and we're going to be at IDEA World in July. So if anyone's going, please look for us, check us out. We get the question of how long does the benefit last? And it varies for everybody, remembering that dehydration, stresses placed on the body, and postural imbalances all impact our bodies differently. So as soon as you start moving, you're obviously going to start wearing that benefit down. So it is recommended to do MCT every time before you work out or you run or you train, and then do one longer cycle, like a regen program created by MCT once a week. And then you're able to kind of maintain that balance. As far as the results of the MCT and the cavus and pronated foot types, were the numbers you stated in degrees? Yes, they were in degrees. And how long after the MCT were the measurements taken? Measurements were taken approximately 5 minutes after doing the MCT. So I did the 5 minutes, and then we did a pressure study, and then we got them on the treadmill and watched them walk. So it was almost immediately after doing the MCT that we then reassessed their foot and ankle mobility. Can you access the study done at Peak Performance, New York City? Yes, please email me at dremily@ebfafitness.com. Again, Dr. Emily at ebfafitness.com, or education@ebfafitness.com, and I can send the study that we did at Peak Performance to you. The one that we did, the first study looking at ankle mobility, that was presented and published at the American College of Foot and Ankle Orthopedic Medicine. So that one is published. The one that we did at Peak Performance, we're submitting for publication. So again, please contact me if you would like. If you want the presentation and you do not want to wait for this to get on the website, again, please email me. I have no problem sending you the presentation. So do I have any books that I would recommend for a fitness professional looking to learn more about the foot and the ankle? There's a great book by Val Massey, which has to do with foot and ankle mechanics, which is a great book. Not to encourage you to go to a workshop, but going to one of the barefoot training specialist workshops, we go into a lot of assessing foot types, foot and ankle assessments, functional assessments, and then barefoot programming. So again, the book, if you're looking specifically, I recommend Val Massey. Great book. It's on foot and ankle biomechanics. Any tips on preventing shin splints using MCT? Yes. This is one of the most effective techniques of MCT. I get a lot of patients who do running and they're getting these chronic shin splints. We immediately start integrating MCT into their program, but not stopping there. Once you do the MCT, you have to do eccentric strengthening. Shin splints in runners are a direct result of inadequate dissipation of ground reaction forces. So that means that their eccentric strength and their eccentric endurance is impaired. So one, we need to optimize the muscle that's responsible for absorbing our shock, which is posterior group, soleus gastroc, and posterior tibialis. You got to do that MCT to those three muscles. And then secondarily, you have to do eccentric strengthening, and that will definitely take care of those shin splints. Recapping what the MCT techniques are, again, myofascial compression technique utilizes the footballer. Footballer is a product created by Trigger Point Performance Therapy. Their website is tptherapy.com. Again, Trigger Point Therapy, their website tptherapy.com. They created the myofascial compression technique. They have a great website, great product. All the products have a DVD within them. And again, they're presenting these workshops at IDEA and will be at World presenting the technique. Yes, I will email you the presentation. Can MCT be used as part of a marathon event warm-up? Absolutely. So MCT done as a pre-gen or before workout warm-up is one of the most effective techniques of this modality. So you're starting to warm up and increase that foot and ankle range of motion, which will then free the rest of the body. If you cannot get over your foot and the ankle, the rest of the body is going to compensate and start restricting all the way up to the pelvis. So if you do MCT to your foot and your ankle and then to your psoas and all the way up into the hip, you start moving and freeing the body, which will then decrease your risk of injury and improve your body's ability to absorb those ground reaction forces. So absolutely, I would recommend MCT before marathon event and before training. How can I use a lacrosse ball to help with ankle flexibility? If you're using a lacrosse ball as an MCT ball, then, well, one, you want to be careful so you don't get any bruises. The MCT products have this patented technology, so it's hard on the inside, and then it slowly, as it warms with the body, starts to give, so it prevents any bruising. Again, I would look into using their ball just because you do not want to cause any bruising on yourself or on your client or your athlete. And then it's not just the products that are effective, but it's the technique. So myofascial compression technique is a little like ART, right? It's one step beyond SMR or foam rolling. So again, it's that ability to move your muscle fibers while under compression that is actually breaking up those trigger points. So remember, it's not just the modality, but it's the technique. So again, I encourage you to look at their website, TP Therapy. We have some great presentations. I would look at their website. Charlie had a question on presentations by myself or TP Therapy in London or in the UK. Again, you can check out their website. We are open to hosting our websites on behalf of EBFA, both nationally and internationally. So do visit our website. If you're interested in hosting a website, then contact us as well at education@ebfafitness.com. If I happen to miss your question, please email me and I have no problem hitting you up. If you want a copy of the presentation, then please email me and I have no problem sending that to you. Any last minute questions? Otherwise, I hope to see you all at our April webinar. And again, please visit us on Facebook. Have a great night, everybody.